Hello, everyone. Welcome to this webinar session. Today, I am Dr. Marino Sutedjo from Indonesia. We're going to share with all of you in this webinar sessions with the topic about rotary versus manual. Does it really matter? So I hope you will learn something from this short webinar. So if we are talking about endodontic, we know that the final aim of endodontic treatment is to retention. In this paper, how Salerabi doing some research and study involving more than 1 million teeth and more than 1 million patients. And what the results say that 97% we can retain the tooth over after 8 years. So this is the goal of our endodontic treatment, that we can retain the tooth as long as possible and functioning normal inside the mouth. So like you see in this case, how we can manage and how we can save it until it is 18 years without any symptoms. The lesions also is okay and the tooth is functioning normal. So the key point to achieve this is of course bacterial eliminations, because it is impossible that we do the endodontic treatment on one tooth and then the tooth cannot be functioning normal because there is some periodontitis and the patients cannot use the tooth for eating. So I think in order to be able to functioning normal without any symptoms, first thing first, we need to eliminate the bacteria as good as we can, and then follow by a good restorations. So let's talk about how we can eliminate bacteria inside the root canal systems. And it is not a secret anymore that we need to do our root canal preparations. And by mean preparations, it is something that we prepared for the root canal to be ready to be obturated. So if the key point of bacterial eliminations is preparations, means that inside the preparations we need to create and uh, to perform shaping and cleaning inside the root canal systems. So let's start again with shaping, because the rationale of preparations that involving shaping and cleaning, we know unshaped canals cannot be cleaned, and we know shaping is to create volume in order the cleaning to be functioning inside the root canal systems in a good way. And then shaping, always we use instruments, and cleaning we use irrigants. And that's why we need to understand that shaping and cleaning, it's all related and it's all working together. We need to shape to create volume in order our irrigants to be able to reach the apical part of the root canal and clean the systems inside. Otherwise, the cleaning will not go inside and it will not succeed to clean the root canal systems. So files definitely they only shapes, and irrigants will clean the systems. But if we cannot shape our root canal up into its terminus, it means our cleaning protocol also will not work 100% inside the root canal systems in a good way. And if we want to create our shaping, if we want to create our volume inside the root canal systems, this is the classic 5 designs objective of shaping that Schilder already spoke about it many years ago, and I believe and it still works and it's still accepted until now, in which most of all the rotary instrumentation systems will definitely adapting these 5 objectives of shaping. First thing is how we continuously shapes a tapering funnel from the apex cavity to the apex. And also, secondly, the cross section diameter should be narrower at every point apically. It means also the preparation should follow the flow of the original canals. So it means if we have a J shape, we don't want to make it an I shape because it will changing the shape of the canal. So if we are not if we are also not allowed to change the shape of the canal, it means the apical foramen also should be in its original position. And the last but not least, that the apical foramen should be kept as small as practical. So these 5 design objective of shaping, it is something that we need to highlight it uh, to be applied in our shaping protocols. So in order to create this 5 designs objective of shaping, it means now we need to understand that we need to create our taper instrumentations. By having a taper instrumentations, of course, we will maintaining our root resistance because our root also have a conical shapes. It will also improve our irrigant efficiency. If you have a paper instrumentations like in this ship, you know that the irrigants will reach easier in the apical part of the root canal systems. And then also it will create a good apical stop. So if you want to, let's say, perform warm and vertical condensations obturations, it will make sure that the gutter percha will not doing any overextensions. In this case, it will improve also obturations, and if we have a taper instrumentations, we can have a good visibility into the regional systems. So, in order to create these taper instrumentations, Schilder mentioning that we need to follow these three phases of instrumentations. First things, we need to do negotiations of the root canal systems prior to glide path creations, and then we also need to determine our working length. And the last phase, which is to enlarge our root canal systems until we finish shaping the apical part of the root canal systems. And I want us to see each phases that Schilder has mentioned, so we be able to understand what I want to say about the rotary versus manual in these three phases. First thing, we need to negotiate our root canal systems. By we negotiate, some terms also can be works the same like scouting. It's all the same, but the definitions of negotiating or scouting the root canal is that we need to explore the original shapes and the original curvatures of the root canal systems. And how we doing this? Of course, we're doing this by using a small diameter files as an initial file that goes into the root canal systems with watch winding motion. Let's see which winding motions that I meant we should use with our K file when we want to do our negotiate. So we want to insert our 10K file as a small files. You go with watch winding 90 degrees clockwise and 90 degrees counterclockwise until it reach the working length. When on the way reaching the working length, you feel some resistance. Do not push. Take it out, and then you want to go inside with watch winding motions. So it is not full 360-degree rotations. It is also not push and pull. It is watch winding clockwise, counterclockwise, clockwise, counterclockwise. When you see any resistance, take it out. Because when there is a resistance, it means that the file at that time is cut and shape the root canal wall into its sizes, the same with your instruments. And after you reaching the point that you want to scout, make sure you do some smoothly in and out motion to smoothing the root canal until it is the same sizes with your instruments that goes in. So this is how we do our negotiation at the first phase of our root canal instrumentations. And after you create your negotiations, and then you want to go into the next step and the next phase, which is creating the glide path. Glide path basically as a creations of the root canal with the smooth walls without any irregularities that works as a guide for the tip of the rotary. Whilst that goes into the root canal, it will facilitate their penetrations and also their maintenance of the original endodontic anatomy. And glide path, it is something that's also crucial because if you already created glide path with a good glide path, adequate glide path, in my opinion, 60, 65 to maybe 70% of our job in instrumenting the root canal systems has been checked. Because the difficult part is creating a good glide path in order to the next step to be able to follow this glide path into its apical part. If you are talking about glide path, well, actually, glide path is used in aviation's industry. When the aircraft wants to land, they follow the specific glide path, which is the smoothness, the glide path, the smoothness, also the landing procedures of the aircraft. And by mean glide, the definition of glide actually is something that it must be smooth, it must be effortless, so you don't need any to do any forces. So it means it's just follow the glide, and it's mean it is smoothless and also it's effortless in a way. So why this glide path is very important because it is gave us many advantages. It can reduce risk of the breast extrusions. It will also improve the preservations of the original anatomy. It is also reducing the risk of file fracture. So Client pad prior to shipping, it is something necessary need to be created in our root canal systems in order to give us a more advantage and creating a shapes that we need that we wanted to have in our root canal. So first phase, we want to do our scouting. Take your small scale files. By means small, in my opinion, is either number 8 or number 10. I never thought number 15 is a small files, it's a big files, and also number 6 is also the smallest file. Some might like the number 6, but I don't like number 6 because, in my opinion, it's too small. It doesn't have any penetration power. When you insert it, it's very easy for the file to be twisted. So my best options to doing negotiations is either you use number 8 or you use number 10. And then after that, we want to follow it with the client path creations after we negotiate our regional systems. And what about the second phase, which is the working line? So I want us to see how important is the working line in our instrumentations. We know this is the study that create a 10-year retrospective study and what is one of the factor that improving our endodontic treatment? It is if we have the root canal fillings of the correct length. So it means if we have a good length, it means it will also give us more advantage by having more long-term predictability outcome of our treatment. And this is also interesting because, and not just interesting, but also it's frightening at the same time, because we know from this study back in 2003, if we are dealing with apical periodontitis cases, if we lose 1 millimeter in our working length, it means it increased the chance of failure by 14%. So it is not a small numbers, it is a huge number. So it means if we are losing 2 millimeters short our working length, we might have a failure chance by 28%. So I think that's why working length is also important because the purpose, of course, is to complete the debridement. We are not we are avoiding to create a traumatic to the periodontal ligament, and then we also need to establish the distance while we want to ship. Completions of the preparations, also obturations, and the last things that determine the success and the survival rate of our endodontic treatment. But the questions remain the same if we are talking about the working length. Where should we stop? And of course, between the three options, radiographic apex, apical foramen, and apical constrictions, of course, the answer will be always the same. We should stop at the apical constrictions because the apical constrictions it is actually is the last dentin available inside the root canal systems, and beyond the apical constrictions, it's just cementum, in which way the pulp will not be attached into the cementum. So if we want to perform our endodontic treatment, we need to measure our working length until the apical constriction. And how we measure this? Of course, we have two famous options. Also, actually, we have many, but the two famous options are is we going to measure with the X-ray, and then we are also be able to measure with our electronic apex locator. So let's see if we want to create a working length determinations using an X-ray, because it's the most commonly used, but we need to understand because it's only providing a two-dimensional image, which is maybe it's not sufficient informative because we know sometimes it's also depend on the angulations. It can be shortened or it can be lengthened, so it is not 100% accurate. And one thing for sure, the most important one is that the radiographic apex that we see on the X-ray as a guidance for our working length, it will not always be the same with the apical foramen. So, for example, I give you this image. Do you think the working length is good? If you see from this side, it looks like it's short, but do you ever think about what it looks like on the other side? Because the X-ray only gives us two-dimensional from the buccal to the lingual or the buccal to the palatal. It never see the mesial or the distal unless you want to measure working length using CBCT, which is I think it is a bit too much. If we see from this side, actually it is not under, but it's overshoot for a few millimeter. So instead of we think it is sharp, it's over. So X-ray, in my opinion, you can use for confirmations, but you cannot use the X-ray for measuring and determining the stop of our working length for instrumentations. And the second, and which is my favorite, and I think it's the most reliable and the most accurate technique to be used in working length determinations, is using the electronic apex locator. It works with frequency, in which way they can read the moisture tolerance inside the root canal systems until it reach the apical constrictions, which is the last part of the dentin. That in this way, we cannot beat this apex locator. There is a study in Journal of Endodontics in 2012. You can see both in vivo and also in vitro, the accuracy of using the apex locator to determine our working length is quite high, 70 to almost 100% in accuracy. So that's why one thing for sure, I will rely my working length determinations always with apex locator. And how it works, you can see you insert the file and then you want to clip it. You want to clip it at the metal part, and then you keep continue do clock the watch winding until it gives us this reading. It means it's over, and you want to take it out until it reaching the zero point 0.0. So you know this is the working length that you should stop. And then after that, you want to reduce the rubber stop until it reference point. So you creating the distance for your instrumentations, and then you definitely need to measure the working length of this canal. So we also need to understand that the working length using the apex locator is just to give you a confirmations where you should stop. So it's not to uh, finding the working length. It's not to counting the working length. We need to count ourselves. It's just to determine where the stop that you need to measure for your working length determinations. So how we usually do these negotiations and working length, because if the determinations of the working length is at the second phases, it means while you negotiate, you don't have any determinations of the working length. So usually while I negotiate, on the way I do negotiate with my 10K files, I then take my apex locator to clip on the file, and then I continue my negotiation. So I'm doing phase one and phase two at the same time to make sure I know the correct length that I should negotiate and scout. So last phase of our instrumentations is the enlargement. This is the main questions. So manual instrumentations versus rotary instrumentations. Do we it's really matter for our protocols? So let's see, I want you to have this insight, starting from the glide path. We know if you want to create glide path, uh, it is very important for us to be able to create an adequate glide path in order the enlargement of the file, enlargement of the root canal can follow the path in effortless way. So we have two options. Either you want to use a manual glide path or you want to use a rotary glide path. If you want to use manual glide path, so for example, I'm using my 10K file as my scouting files, and then after I scout and I know the length of my root canal, then I need to increase with, let's say, 15, 20 until it is reached the size that it's almost matched with my enlargement files. Or secondly, you can use a specific instrument that has been designed to create a glide path in a mechanical or in rotary way. Let's see if we want to create a glide path in a manual game. So I'm using once again a K file. I want to create a good glide path, watch winding, take it out, take it when the resistance, take it out, and then you want to go inside again. And once you reach the working line, make sure you stop and you want to smoothen the root canal with your K file. no pressure or light pressure. I don't want you just to be too fast on this in and out. I don't want to say push and pull, because sometimes if you think push and pull, it means it needs more pressure. So I like to say the word just in and out in a smoothless way. And then if I want to create manual class pad, it means now I need to increase the 15. And this is the difficult and this is the challenging part. Because if using stainless steel files, the bigger the file, it means the stiffer the characteristic of the file. And it will create more challenge. It will create more risk of ledges. It will create more risk of anything inside the root canal systems. But sometimes we have to do it in manually, and at that time we don't have any options. So at that time, if we want to create a good glass pad manually in a very severe curvature canals, I don't know, some of you maybe remember this golden medium files. They have a size of 12, 17, 22, 27, and 32. So for example, in this case, at that time, it was like years ago, I don't use a rotary glass pad because it is not available in the market. So I need to use my manual file, which is I increases from 10 to 12, 12 to 15, 15 to 17, until it reached the 20 or the 22. So in order to be safe in using my enlargement instrumentations. So I just want us to see the literature and the study about this manual versus the rotary, because the rotary glide path, from the study that I read in 2012, it will create less post-operative pain, it will create less debris extrusions, because if you do manually, sometimes the debris have more risk to extrude it outside apically, compare if you're using rotary. Because if you're using rotary, the debris will automatically, it's easier to come up coronally instead of we forcing the debris apically. And then also, this is a very good study from Cantatore, Castellucci, and also Professor Elio Beruti. They are comparing clinicians in expert clinician and in expert clinician, and they ask those two clinicians, either expert and inexpert, to use manual and also the rotary clad pad. And what we can see from the study, this is the manual clad pad. The result from the expert. There is an enlargement in the apical part, and when the inexpert use this, the enlargement at the apical part is huge. It's wider. So this is why also the debris extrusions on the manual clad pad will be higher, because the apical stop cannot be maintained. It's enlarging and it's flaring because of the stiffness of the file. And when the clinicians use the rotary, both expert and inexpert, you can see it is way better and it's way smaller and it is way less deviations inside the root canal systems. So on your left side is the manual glide path. You can see this is the 20K file. It's a stiff file, and it has a cut at the tip. That's why it cannot smoothly in effortless way goes into the apical part because of the stiffness and the sharp curvature. And if you try to use this, and then you will create an elbow, and once you create an elbow, once again, it's very difficult to go back in again into the canal. You need to pre-cut the file, you need to go down one size smaller until it can be bypassed. Comparing if you're using rotary glide pad, that is actually easily, in effortless way, they can slip and slide until it reach the apical part of the root canal without having this kind of risk. So therefore, in creating glide path, for me, I don't think manual is better than the rotary. You can see here, always put some lubricants. In this case, I'm using sodium hypochlorite, and in this case, I'm using a C-path rotary from Fanta. So what you need to do is just light pressure, let the rotary glide pad inside the canal working itself. You need just to take it out and you need to know when you need to put it in. You can see the debris is there, so the risk of debris extrusions is less. So also this paper mentioning that by using a rotary glide path, it will also promote it less deviations from the original anatomy comparing if you're using the manual. So once again, manual versus rotary in creating glide path. I need you to choose your path. You want to choose the safe and relaxing path, or you want to choose the dangerous and the more risky path. And rotary also is safer. It has better efficiency. It is also less canal transportations, and it also has less canal deviations. And once again, it has a less post-operative pain, at least 6 to 48 hours after the treatment comparing to the manual. So definitely manual versus mechanical, in my opinion, rotary always win because it matters. It gives you more advantage in less post-operative pain. It gives you more confidence in shipping without any risk of debris extrusion, less risk of deviations, less risk of ledge. So definitely, in my opinion, rotary or mechanical, it is more advantages. And we also need to understand because if we are talking about the mechanical at this moment, we have rotations and reciprocations, and these two rotations and reciprocations has some differentiate in characteristic. Rotations mean it's 360 continuous rotations. It has a tendency to screw in because it's keep continuous rotating, but it's easier to reach working length and also easier to remove the debris coronally. You don't need to push, you need just light pressure, but since it's continuous rotations, it's also easier to bind in the canal and you have a more risk of fracture due to its torsional and cyclic fatigue. And if we are talking about reciprocations, it means we have some degrees clockwise and some degrees counterclockwise. We have no screw in here because it's not continuing rotations, but it will reach working length a bit easier and longer comparing to the rotations. And we need packing motion in this, and we need to understand because it's not 100%, it's not 360 degrees continuous rotations, so it has tendency to be creating more a debris plaque at the apical. And it also have a good advantage where it's less risk of fracture. By mean packing motion is like this, so one, two, and three. And I always mention if you want to use reciprocation with packing motions, only limit up to 3 times. So one, two, three, stop. You want to take it out, you want to clean your fluids, and you want to irrigate, and you want to continue again. So make sure you are not doing packing motions more than 3 times because it will create the risk of debris plaque at the apical. And if you want to use a rotary, I don't mind any brand, any sizes. All in my opinion, you need to always follow this mother-in-law rules. Don't stay too long. What I mean, don't stay too long. Keep the file moving. You do not want to stay in one positions for few moments. You can see from this video, this is the timing. 10 seconds. If you keep pushing this, there is some tension and also there is some uh, compression in this file, and less than only take 15 seconds the file break. So first rules, do not stay too long. And then second rule, you don't want to push too hard. So what I mean by don't push too hard is just like writing using a sharp pencil. If you are not pushing, you cannot write anything. But if you push too hard, once again, the tip will be broke. So once again, we need some uh, feeling about this. Just light pressure. Just follow the files goes into the root canal. And the last and the most important part of the rules is that when you're done, you need to get out. So what I mean by if you're done, you need to get out. So you can see here, if you want to ship, let's say go in, you feel resistance, take it out. You go in again, you feel resistance, take it out. And then, no, 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 I want to make the root canal clean. As I told you, the files cannot clean, the files only ship, and you try to repeat it several times, see what happens inside. You can see at the apical part, there is some enlargement and the S shape now is changing slightly into the J shape. It's strengthening here. So this is something that we do not want. And how if you're using the bigger files? The bigger the files, of course, the more challenging because the file will be stiffer. I don't care what material you use, the bigger the file, definitely it will be stiffer. So once again, when you reach the working length like this, you want to get out, it means you're done. You don't need to reshape again. If you want to reshape, let's say one time, two times, it will be fine. But there is no necessity to repeat it several times because if you repeat it several times, you will see what's happening inside the root canal. This beautiful S shape will change into the J shape, and the apical enlarging is happening. It's very difficult to control the apical extrusions, and you are changing the positions of the apical foramen, sometimes something that we don't want to have in our design objective. But the rotary also have in rules that we need to use the RPM and we need to use the torque. RPM by means the speed rotations, and the torque is the apply force into the file into the something that it can rotating. So I'm going to introduce you my one of my favorite uh, endodontic motor, which is the iRoot Pro from Fanta. And what I like about this motor, you can use this in any instrumentation systems. It can be adjusted both torque and also the speed. So it also can be used for the rotary and also can be used for reciprocations. And you see here is the if it is forward, it means now it's 360 degrees in rotations. You can also change the settings into the counterclockwise, which is the reverse. The speed can be we can adjust it from 150 to 800 RPMs, which is quite high enough. Sometimes 800 needed to be used with, let's say, kids clean drill, and it also can be used with the reciprocating file. You can adjust the degree of the clockwise and the degrees of the counterclockwise, since not all the reciprocating systems has the same angle. So you can set your specific angle of your reciprocating systems. For example, this is the reciprocations movement, which is I set 30 and 150, 30 degrees counterclockwise and 150 counterclockwise, and this is the rotation movement. And also, this iRoot Pro is also can be connected into the apex locator, so you can work your rotary and I mean you can shape your canal while you attach the apex locator, so you know exactly where to stop. Because it is important that this study in Journal of Endodontics in 2017 that the simultaneous length control during root canal preparations, it is one of the non-pharmacologic strategy in reducing post-operative pain because it will also reduce the risk of debris extrusion. So in my opinion, if you use your iRoot Pro and your rotary files or reciprocating files, it is almost the same. You use your files plus the apex locator. So it means you have apex locator, you have endodontic motor in one equipment or in one gadget. So this is one of the advantage also using the rotary instead of manual. You can see in this case there are missing canal in this lower premolar, and in this missing canal is caused by the tip split. From the CBCT, I need to measure the split level. As you can see here, that's the 13 millimeter distance from the reference point, and then you'll be able to see the split level. I need to enlarge my access cavity in order for me to be able to identify the opening. And after you identify the opening, you can prepare your files, and then you can use your rotary instrumentations. So, because if you use your hand, it means you will definitely block your vision and you will not able to see the entrance of the orifices. But if you use motor and you can prevent your file like this, you see it's very easy and it's you don't have any obstacle in your visibility because you can see where you need to insert and where is the entrance of the root canal, and then you can continue shape your root canal with your rotary, your favorite rotary systems with this iRoot Pro to be able to achieve the working length. And then you regate, you can see the debris is there. And then after you shape, you obturate, and this is the result. So back into the questions of this topic of today's webinar, rotary versus manual. Does it really matter? In my opinion, it is really matters. So I always choose rotary comparing to the manual. And if you definitely agree with me, and it means we need to use our endodontic motor and choose the endodontic motor that also can be used for rotary files and also can be used for reciprocating file, and make sure it also have a apex locator function. So if you want to use it simultaneously while you shape, you make sure you don't want to overshoot it. Then iRod Pro is one of the answer for your endodontic needs. So but if everything fails with your strategy and using rotary and reciprocating, there we still have our classic manual file to be used. So I also like to invite all of you, if you have time, this August to fly to Sydney, and we all together to join the 15th IFIA World Endodontic Congress in Sydney. So I will be seeing you also there in Sydney. Until then, you take care, and thank you very much for listening and for your attention, and have a good day. Bye bye.